it's a pleasure for me to share our experience with this series that I want to present to you in the context of this LINNC Master course. So we checked our results when looking at patients treated with this combination of techniques. If you look at treatment of aneurysms, definitely there are many ways to treat aneurysms, and today all aneurysms can be treated. So the question is mostly not whether embolization is possible, but which technique should be chosen. And there are many different arguments how to choose a technique. I think that one of the most frequent one is ease of use. If you have to place coils, most operators prefer to have soft coils than stiffer coils because the soft are much easier to place. If you have to place a stent and to control the stent expansion and not sure that the stent expansion is good or not, if you take an invisible stent, then you can say that it's less effort to do than a visible stent where you need to check all details. If you need to get access to the parent artery and to the artery beyond the aneurysm, this may be sometimes technically challenging. If you take a device that just goes into the aneurysm without controlling the parent artery, it's significantly less effort. So these may be reasons why to choose a technique. But there are other reasons, such as in ruptured aneurysms, antiaggregants are definitely a problem. So balloon-assisted coiling will be certainly better than stent-assisted coiling, where you have the difficulty of using the antiaggregants. The duration of antiaggregation may be another point to consider. And in a patient where a flow diverter is being placed, today you cannot avoid lifelong antiaggregation with regular stents. And the one that I'm going to present here, after 1 year, you can stop antiaggregation. Finally, other points can be considered and are probably very important if you consider that all aneurysms can be treated, which is, why shouldn't I choose a technique to obtain a stable result? And from this point of view, there is a difference between coils coated with hydrogel and bare platinum coils. And if you look at the results in the literature, and these are series that are, some are very recent. A hybrid study from Japan just came out now, and the other one are a little older. But all series that have been done comparing platinum coils to hydro coils showed that there was a significant difference in terms of recanalization rate. Choice of technique would be also whether to use a balloon or not. And in my opinion, balloon remodeling is something which is very important for treatment for various reasons. In the literature, you find everything. You find arguments pro, argument against using a balloon, which is very often dependent on the experience of each operator. But you see an increased sentinel use of the balloon in order to keep the balloon in place and just inflate in case of problems such as an aneurysm rupture. So of course, I think that balloon remodeling is a good thing. And I found out some articles in literature that are promoting the use of balloons, such as the study from Chapot showing that there is a higher initial rate of occlusion, but also on the follow-up, which is also what is my experience. The Athena study organized by Laurent Pierrot showed also that there are less thromboembolic complications when handling a balloon. And you can easily imagine that because of the control with the balloon, you avoid the coils to protrude in the parent artery. So why a balloon? Very simple things. It's the best way to understand anatomy. And we're not missing images where you have usually this kind of frontal projection where you say, this is here's the neck, separating the aneurysm from the artery. But if you consider a cut through this plane, where you would see the artery here. And if you consider the plane that we had before, then occlusion of the aneurysm would be this. But if you follow this line and this rule, you miss all the inferior part. So just checking on the line not to cross is definitely not enough, and the balloon helps you to avoid these problems. So whenever you use a balloon, you always realize that your optimal working projection is not so good, because at some point you get coils that are over-projected to the balloon, and by changing the working projection, you realize that there is a working projection which is better. So definitely the best way to understand the anatomy, certainly also control of bleeding. And even if bleeding is not so frequent, this is an issue. And you would imagine someone doing parachute, not having a second parachute to control blood. But if we treat aneurysms, we don't have a security system to control bleeding. I think that's not okay. Other arguments, stabilization of microcatheter. And this is something which is really important in certain situations, such as this bifucartion aneurysm at the carotid T, where you certainly also experience that placing a microcatheter here is quite okay, but keeping it stable is much more difficult. And if you place a balloon in one artery, you may push the microcatheter towards the other one. But if you have two, as on the right picture, then the microcatheter will be stabilized by both balloons. And this way enables you to treat your aneurysm properly, to coil it. And we also added here a stent at half T in A1. Another reason to use balloons is just that it's much more easy than any stent to go in and out the aneurysm. And you can keep the microcatheter at the neck, which is the safest way to coil an aneurysm. Whereas if your microcatheter is at the fundus of the aneurysm, you may be more aggressive and increase the risk of rupture. Reaccess to the aneurysm is a point I just mentioned. So the series of aneurysms we're considering are aneurysms where we use mainly hydrocoils, where we always use the balloon, and where at the end of the procedure we place a stent through the dual lumen balloon. So why to add a stent? Because there is a growing level of proof in the literature that when you add a stent, you reduce recanalization. This is a series of the Fondation Rothschild, where the difference was very significant between what Michel Piotin showed. It was then another author that found very similar results. And there are many of results like this in the literature. This is our own experience, just combining stent and balloon before the stents could be placed through the balloons. And if we look at this series of 87 unruptured aneurysm, the initial occlusion grade was, as you can see, 67% grade 1, 23 grade 2, and 10% grade 3. After 12 months, is it the hydrocoils? Is it the balloon? Is it the stent? Probably a conjunction of three factors to enable very high stability after 1 year. And this is one example of this parophthalmic aneurysm, coiling with the balloon. The stent, in the end, you can even place a balloon in a stent to make sure that the apposition is fine. And this is a follow-up where definitely this aneurysm is cured. There is no need to make further follow-up here because this will remain like this. So why to combine stent and balloons? Because now it has become very simple and easy, since stents are available in 017 compatible microcatheters, so that they can place through a dual lumen balloon. And here's an example of this pericallosal aneurysm, where the aneurysm is coiled with assistance of the balloon. You see that the microcatheter is kept at the neck. This way you're very safe during coiling. Here is after coiling, and then the wire is retrieved, and through the balloon you can place the stent, here baby Leo, and even you can do an instant PTA, which is the best way to know whether your stent is properly and fully expanded or not. This is here the immediate results. And this is here the follow-up 1 year later, where definitely it's occluded and cured, and even the small associated aneurysm located more proximally is almost gone. So the stent through balloon technique is very easy to do. Helps also to avoid any concerns for the last coil. Should you place a coil at the neck or not? In case of doubt, you should not. But if you can add the coil without any risk, because even if it's a bit unstable, you will fix it with the stent, it's a way to even increase the level of pecking at the neck, which is probably the most important. Third point, which is not less important, doing a CT before placing the stent. I think that the worst situation in stent-assisted coiling is to have a situation where you have a patient having some acute bleeding from a distant branch or from the aneurysm from somewhere, so that you must avoid all anticoagulation and all antiaggregants. But simultaneously, you already placed a stent and you need to give this dual antiaggregation. And this is a very challenging situation because whatever you do, it's wrong. If you stop antiaggregants, your stent will thrombose, and if you continue, the patient is going to continue to bleed. And that's why if you place a stent in the end, in order to stabilize and to gain stability, you can do this after having done a cone beam CT. And today all machines have cone beam CT available. You make sure that there is no blood, and then you can place a stent to finish the procedure. So this is a series of our patients. We've been using this technique since the Scepter XC is available, which is beginning 2012, and the baby Leo was available at the time too. So 850 aneurysms treated this way since January 2012 until the end of last year. So 9-year period. Hydrocoils, balloon-assisted coiling, stent through balloon, mean size of aneurysm 7 millimeters, follow-up, which is done systematically at 1 year and 5 years later. Location of the aneurysms, more than 1/3 of those aneurysms were MCAs, but also a lot of ACOMs and basilar tips. Almost or very few ICA. You will see 16 ICA aneurysm. Definitely the stents were until the Elvis Evo come out, the stents were too small to be placed inside the carotid artery. So you may use flow diverter or something else for the carotid artery. But here, all the small, all aneurysms located on small arteries, just like, PCOMs with fetal origin of the PCOM, or pericallosal or superior cerebellar, PICA, are the typical aneurysms to be treated like this. Technique, we used even a bit more often 2 balloons in 53%, 1 balloon in 47%. It's interesting to see that before using 2 balloons, I had a lot of concerns and I hesitated some years. And now it has become a very standard way to proceed, and persons in my team, in case of doubt, that prefer to have a second balloon because they feel safer to control everything. Whether to achieve an instant PTA or not, you see half of the aneurysms had, after delivery of the stent, placement of the balloon inside, just to check whether the stent was properly expanded or not. The stents that were used, mostly baby Leo, juniors were not used so often. Elvis Jr. did not behave that well. But Elvis Evo arrived 1 year ago, and we've been using a lot of Evos in the meantime because definitely it behaves now very nicely. A couple of Aceros, Atlas, and Aclino have been also used. Type of stents, regular stenting, I mean, from covering the neck from one side of the artery from the distal to the proximal part, but also half T stenting in 250 situations, or T stenting in 77, or H stenting, which is in ACOM aneurysms, where you protect A1, A2 on both sides. So what is a T stenting? I guess everybody knows this in the meantime. Here is the first stent, here's the second stent, in order to avoid crossing the struts of the first stent to get access to the other artery. This is specifically useful when access to both arteries is difficult. And this way you make sure that the second stent will be properly opened. This is the advantage. The drawback is it needs to be very precise. And if the half T is placed a bit too distal, it makes no sense. So that's certainly a good technique, but you need to be very precise to do so. Evolution then from T stenting to half T, because we had some ischemic complication when placing two stents, and definitely it's more dangerous to place two stents only than one stent, especially when using braided stent. So we evaluated also from multiple to single stents. Here is a typical situation where you have a double curve when your stent has to be placed from the artery distal to the aneurysm to the neck and then proximally. And whenever you have this S shape, the stent may open, but it's not so easy. So if you have only one curve and placing your stent a little more distal, but like this, then the stent always opens very nicely. But probably it's better to have filled the aneurysm with coil before, otherwise the stent may protrude inside the aneurysm. So this is here a half T stenting which has been made, as you can see here. And here another example, challenging aneurysm located on M1. You need to find a way here to get access to this little artery, and two balloons are placed here. This aneurysm is very small, but she ruptured an aneurysm on the other side. So this is coiled, and you don't want to place a stent from the temporal branch to M1. So this is the way the stent is placed through the balloon in half T with the immediate result. And this is here the follow-up, where you see now that it's completely cured. And this is the follow-up at 1 year. Here, other situations where half T is very useful in superior cerebellar aneurysms. This is an aneurysm located on the superior cerebellar, not on the basilar. No doubt that some persons would want to place here flow diverter, but is it so good? There are many arteries to be bridged. I think the safest way here is to bring a balloon in the SCA. You don't need always in the basilar and PCA, but it's easier to coil this way. And in the end, you can control very well the delivery of your stent, which is, as you can see here, just until the origin of the basilar. So the occlusion rate that we could obtain using these techniques was 93% of complete occlusion at the end of the procedure, 3% with a small remnant, and 3% that were completely occluded. And the follow-up available until now in this series for 56%, so a little over 400 patients. We're working on the data, and I'm going to publish it only once we have a higher number of controls. We have 90% of complete occlusion of the aneurysm at a mean of 2 years, 7% of dog ears, Raymond 2, and 4% of recurrent aneurysm. Here's an example for small aneurysm at the pericallosal artery, where small aneurysm, small artery, where you may access, but it's not so easy. So definitely balloon and coils. And Here you see the coils, you see the balloon which is deflated. To do the controls here, we needed to have a third microcatheter because the control to the guiding did not enable to do so. So this looks good. The balloon is inflated now distally. Now balloon is inflated in the artery. You see somehow overinflated, and then we're placing a stent, which is here an Elvis Evo with some instant PTA after, some over expansion of the stent in front of the neck. And this is the immediate result controlled by the microcatheter, which looks good. But definitely it was a mistake from myself, because when I took the microcatheter out, the control from the guiding was not so good. I was very disappointed here. But look at the result 1 year later. Finally, we see that there must be some flow diversion light effect of the braided stent. Here another example of this quite large MCA, which is, you see here both division branches coming out of the aneurysm. Here is the view of the 3D with again both division branches to be seen. And an attempt first to have a balloon in one branch and Elvis Evo in the other one, but it's not so easy to open properly the stent, even if the stent is definitely good. But you see very proximally, it's still not completely opened, maybe because you're still holding the stent, but you don't know. Is it going to open completely if you release? So finally, I prefer to here retrieve. You see, I push here the stent. It's more overexpanded in the neck, but in case of doubt, I prefer to take the stent back and to treat it with 2 balloons, finish the aneurysm by coiling, and then the stent was placed in the end. And you see here, if you push with the stent to the aneurysm, it cannot protrude inside the aneurysm. And now the stent has been delivered. You can do some instant PTA. There will be no risk of displacing the stent inside the aneurysm this way. And definitely this is the immediate result here. And this is the follow-up at 1 year where this aneurysm is cured. Nothing remains, and definitely it's fine. This is a pike aneurysm treated with balloon-assisted coiling, but you see balloon is very often not enough. So half T stenting in the pica, and this is immediate result. Here's the follow-up. And where you can see here is the stent in place. Same thing here, this aneurysm previously treated, still important recanalization at the level of the superior branch. Again, balloon-assisted coiling. Then the stent was placed in the superior division branch, half T, just one stent. And this is here the result and the follow-up. That was the follow-up. Here a PCOM, since the Elvis Evo is available, you can treat this. Of course, you can treat this with a flow diverter, but you will need one lifelong interrogation. Whereas if you go on with balloon coils, it is simple to do so. And through the balloon, you can bring here the stent, the Elvis Evo, that goes up to 4. And here we did a bit of too much shouldering beyond the aneurysm. So you see we retrieve a bit the stent. Here the stent has been delivered. It's not over-compressed distal to the aneurysm, but just in the position where you want to. So which technique to use? Each technique has drawbacks. I mean, flow diverter, I'm not sure that bifurcation aneurysms are ideal, because if you have a technique that induces progressive occlusion of the side branch, this should not be our way to treat aneurysms. In our opinion, lifelong antiaggregation is an issue too. Flow disruptors, it's a very handsome and sexy technique, but about 1/3 of aneurysms are accessible. So what do you do with the other one? You may send them to surgery, but if you want to treat them by endovascular, the technique I just presented always works. And not sure that the stability of results with flow disruptors is so good. If you consider the stent through balloon technique, it may be technically a bit more challenging, some more efforts, but in the end, you can treat all aneurysms, probably in larger aneurysms. As soon as an aneurysm is more than 10 or 12 millimeter, the risk of having some recanalization is growing, and those aneurysms may be rather considered for flow diversion. So as a conclusion, definitely with this technique, while combining everything you can do to obtain the best possible result and the high stability, with this technique, we obtain a high rate of immediate occlusion, a high stability, and definitely in our hands, it seems to be the treatment of choice for small and middle-sized aneurysms. And somehow, I think that we can consider that braided stents that goes to a 0.17 lumen should be considered as flow diverter lines. Thank you.